My name is Is Jones. I'm a medical oncologist with Infirmary Cancer Care. The classical definition of chemotherapy is drugs and chemicals that are used to treat the fastest growing cells in the body. And in the human body, cancer cells grow and multiply faster than any other cells. So chemotherapy is used to attack those cells, to kill those cells. Traditional chemotherapy has kind of been the old way to treat cancer. Now with the development of targeted therapy and immune therapy over the past several years, chemotherapy has become modernized, so to speak, and we're really able to treat cancer with minimal toxicity and more effectiveness. Targeted chemotherapy is actually specifically honing in on a specific aspect of the cancer cell, whether it be a molecular abnormality, an abnormality on the surface of the cancer cell that normal cells of the body do not harbor. So these agents are able to attack those specific markers, kill those cancer cells with relative to no toxicity related to normal cells of the body. Chemotherapy works by targeting cancer cells when they're their most vulnerable, and that's during their cell division. It will target them at a specific aspect of their cell division, cause DNA damage within the cancer cell. The body knows that that cancer cell is not supposed to be there. It's able to attack the cancer cell and thus kill the cancer cell off. The majority of patients that we see are good candidates for chemotherapy. One of the things that a lot of people think will preclude them from getting treatment is age. And that's simply not the case. I've got several 90-something-year-olds that I treat with chemotherapy. It's simply knowing who to treat, when to treat, how to dose them, how to modify the treatment regimens when appropriate, and how to give the appropriate supportive care to get them through what can be a very tough treatment regimen. So I would say virtually everyone that walks in my office is potentially a candidate for treatment. I tell them it's going to be a long road. I don't want to lie to them. I don't want to give them false hope, but I want them to know that there is hope, and that with supportive measures, with the team approach, that we're able to get them through this tough time. They're of course going to have to rely on their family, who's going to be there for them every step of the way, but they need to know that we're there for them every step of the way as well. And we know what we're doing, and we can get them through this toughest time of their life. But what I tell people is that they're not alone, and I don't treat them alone. We take a multidisciplinary approach to each and every patient. We talk about them in different conferences. We discuss them over the phone. There is a true multidisciplinary approach with each patient. We are able to tailor their therapy to whatever their disease is, to whatever their health status is, and whatever their treatment should be. This is not a cookie-cutter approach. Each patient is different, each disease is different, and they should be treated differently and uniquely. You know, chemotherapy, in quote, the old days, you got chemotherapy, you went home, you threw up for 3 weeks, you came back and you did it again. And it's simply not the case anymore. With the supportive measures that we're able to give patients, we're able to alleviate side effects, if not eliminate them completely. Nausea has always been one of the fears of chemotherapy. We're able to control that almost completely nowadays with the supportive care regimens. And again, treatment has changed dramatically over the years. We are still giving traditional classical chemotherapy agents, but we're giving targeted agents. We're giving immune therapy drugs that are allowing the body's own immune system to attack a cancer cell. So we're not really introducing a foreign agent. We're just basically telling the immune system, hey, it's time to ramp up and do your job. Hair loss is, of course, a big physical and psychological impact to people that are on chemotherapy. The important thing to know is number one, not all chemotherapy does cause hair loss. The second most important thing to know is the hair will grow back. The peak incidence of hair loss is about 1 to 2 months after starting a chemotherapy cycle. It does typically involve hair throughout the body, not just from the scalp, but eyelashes, eyebrows, facial hair. So it is a significant impact on patients, but it does grow back. It can happen all at once, clumps of hair falling out overnight. It can be a slow process over a several-week period of time. But once the chemotherapy is over, and it works its way out of your system. The hair will grow back, and oftentimes it's thicker and curlier than ever. What I want patients to know about chemotherapy is that we can get you through your regimen. Cancer is a life-altering diagnosis from every aspect of your life, and there's fear, and fear is one of the biggest things that I want patients to realize, that it's okay to have, but don't let it dominate your life. Don't let it dominate your treatment protocol. We will get you through your treatment regimen, whatever modifications we have to have, whatever we need for you at home or during our clinic visits, we will get for you. We will get you through the regimen. We'll treat your cancer, and with the full goal of completely curing your disease. When I have a patient that's beginning chemotherapy, I really sit down with them, and our team does, and go through every single aspect. How long is the treatment going to take? Is it going to be an hour? Is it going to be 4 hours? What can you expect in terms of side effects? When do you need to call us with those side effects? How long is the treatment going to take? Is it going to be 3 weeks? Is it going to be 6 months? So I really try to make sure that we cover all of our bases so there's no surprises along the way, that they know every detail that could come up during their treatment plan. And also I tell them if there is a question, if there is a problem that has not been addressed, we need to know about it. And if that's in the middle of the night at 2 in the morning, we want to hear from you. We need to know what's wrong with you so we can help fix it. Chemotherapy can be administered in several ways. Classically, chemotherapy was only available through IV treatment, whether that be through a peripheral IV or through a central venous access device. And we still do administer chemotherapy in that fashion very commonly. But we're now able to administer chemotherapy subcutaneous injections, and many of our agents now are available through oral treatment by pills that can be taken sometimes even only once a day. And so a lot of the agents that we're able to give and treatments that we're able to administer can be given through oral chemotherapy without ever having to receive an IV chemotherapy agent, which of course makes it a lot easier on the patient. You don't have to spend time in the chair and in the chemotherapy suite for several hours, whether that be once a week, once every 3 weeks. We still do administer IV chemotherapy, but the development now seems to be away from IV chemotherapy more to a more patient-centric type treatment. Chemotherapy myths are common. A lot of them do hold water from, quote, the old days when chemotherapy was so toxic. And in those days, it was a rough go. Everyone got sick. It didn't matter what they got or how they got it or for how long they got it. But now we have people that continue to work full-time jobs while on an aggressive chemotherapy regimen for whatever disease that might be. So what I would say in terms of myths is the toxicities are not as bad as you've heard them to be. Sure, there are some toxicities, but we are able to minimize those and sometimes completely eliminate the toxicities during your treatment. And we can get you through your therapy and impact your quality of life as little as possible.